My name is Mary and I'm a Community Resource Officer with Epilepsy Ireland, and delighted to welcome you all here this evening. And tonight we're going to be discussing menopause and perimenopause. So something that will potentially affect a lot of women to various different degrees. And in terms of epilepsy and seizure management, many will be aware of the common triggers and know that sometimes significant changes in our lives might also impact epilepsy. For some women, symptoms of menopause could potentially maybe affect seizure frequency and maybe our overall well-being. And for others, that may not be the case. So we're here this evening to try and better understand the changes that may occur and look at some of the options in terms of managing those symptoms. So we hope that by better understanding perimenopause and menopause and being more informed will lead to better outcomes in terms of quality of life, reducing stress and anxiety, and recognizing and managing triggers as well. We are, though, very mindful that women will have very different experiences of epilepsy and also very different experiences of menopause. So I suppose with that in mind, we can only give information and advice based on the evidence that's available to us. And we would always urge people to talk to their doctor or their team if you're planning on making any significant or major changes. So this evening, we're going to have two presentations. So just as I explain that, I'm just going to come off of the share screen there. So we're going to have two presentations this evening, followed by a question and answer session. And we're really fortunate this evening to have some expert speakers with us, and we are extremely grateful of their giving of their time this evening. So first up this evening, we're going to have Maher joining us, and she's going to talk to us. Kathy is a pharmacist. She's the chairperson of the Irish Pharmacy Union. She's a women's health advocate and has also recently completed a diploma in women's health in primary care. And Kathy has a wealth of experience. Following Kathy, we'd like to welcome Claire McElroy, and Claire is a clinical nurse manager in the National Maternity Hospital in the Complex Menopause Service. And that's the first of 6 such services to be rolled out nationally, which is a very positive move. Claire has expertise in supporting patients with serious medical conditions to manage menopausal symptoms. So again, really looking forward to their input. We also have with us tonight on the panel Sinead Murphy, registered advanced nurse practitioner. And as well as being an epilepsy nurse specialist, Sinead would specialise in the care of women with epilepsy, and she will be also with us on the question and answer panel at the end. So we will have time for some questions, and as I say, some have already come in, and please do submit any questions you might think of as we go along during the presentation as well. And maybe some of your questions will be answered as we go through. Just one final thing from me, just to say, unfortunately, we're not able to answer questions of a very personal nature, or if it's kind of relating to your own maybe prescription or individual medications and so on. It's just not something we would be able to advise you on here on this platform. So yeah, without further ado, I'd like to hand over to Kathy. So thank you very much, Kathy.
Great, thank you, Mary. As I said to Mary at the outset, technology isn't my strong point, so I hope I can share my screen. It's visible for everyone. Thank you to Epilepsy Ireland for inviting me to speak on epilepsy and menopause and how it affects women. Really what we have seen in terms of menopause conversation has really exponentially grown in the past number of years, and rightly so. And I'm spending a vast number of my day in pharmacy speaking to women in perimenopause, menopause, postmenopause, how they manage their symptoms, but also how they are trying to prevent long-term complications of menopause and hormonal depletion. Just my own quick background, I've been a community pharmacist for more than 25 years, and I have 3 teenage children, so there's lots of hormones raging in my house. Our age group is very much called the sandwich years, and you might find yourselves that you might have partner, spouse, family challenges within the household. You may have elderly parents that you need to look after. You also have children, and you're also squeezed in terms of financial, career. There's a lot going on, and you've all of that to deal with, and as well as manage hormone depletion. As Mary outlined, I have diplomas in women's health management and diabetes management and cardiology, but I also graduated and teach yoga and meditation since 2017, which I certainly feel has helped me in my own perimenopause and menopausal journey. And I always put a question mark under menopausal there. I'm 48, so I'm absolutely sure I'm menopausal. And anyone of my household family could tell you I'm sure I am. So I'm speaking to you as a pharmacist, but also as a mom and also as a woman of your age who's going through the same thing. This is some of the screenshots that we would see in the press over the past couple of years. And some of these advocates have been really vocal in bringing menopause to the fore. What we would have seen in community pharmacy was that prescribing for HRT and menopausal care really dropped off a cliff for a number of years, probably for about 15 years from when I first qualified, because there were some scares around prescribing, around risk. And then it went onto the carpet. Women were largely not listened to. And it really took people like Davina McCall and like Joe Duffy. I think it was the 2 weeks that Joe Duffy dedicated Lifeline to really exponentially drove the conversation around menopause and women's healthcare. And we see now Stephen Donnelly launching a menopause service, and services like Claire's in complex menopause care is really, really vital. So it's really good to see these conversations happening, because the next few slides where I show statistics around how women feel unprepared for menopause, for perimenopause, and the impact that it has on their physical, emotional, and just their day-to-day life is really, really significant. I like the one at the top right with Davina. It's your sex drive fades, your memory fails, your days are sweaty, your nights are sleepless, bones get brittle, can be depressed and anxious, but you feel you have to keep calm and carry on. And now at this point, women now have a voice, and I'm very passionate about making sure that women do have a voice, that they do think, actually, hang on, I'm struggling here. I need help with these symptoms. So what can I do to manage it? Whether it's pharmacological, whether it's through HRT, or whether it's through lifestyle changes and other complementary and auxiliary therapies, absolutely, it's there for you. The bottom right one as well is a poster from New York where it says it's not all in your head. And very often when I'm speaking to women in the pharmacy, they may retrospectively look back and think, actually, I've been having these symptoms for maybe 2, 5, 10 years. And I just thought I was losing my mind. I thought there's something wrong with me. You know, maybe they've been misdiagnosed with other conditions. And actually, perhaps a lot of it is menopausal or hormonal related. So what we're trying to do is really encourage women to be educated, be fully informed, be project managers in their own health, and particularly their own reproductive and their own hormonal health. So it's by events like this that help empower women do that. In terms of some of the statistics, this is a UK statistic and the Irish one pretty much match up. So only 1 in 4 perimenopausal, menopausal, or postmenopausal women felt prepared. And that has considerable negative impacts. More than half underestimated the physical symptoms that menopause would have on them. And more than half underestimated the emotional symptoms, the impact of the emotional symptoms. 85% agreed it had a negative impact on relationships at home. 3/4 agreed it had a negative impact on performance at work. 2/3 had a negative impact on their career. And just under half felt under pressure just to simply cope. And this is something that we may experience from, on average, 7 years, but could be anything from 5 to 10 to 15 beyond years. So it's really important that we do enter this period in our lives, that we feel informed, that we know there is treatment out there, and that we can live the rest of our lives to the fullest. There are now almost in the last 10 years, there's a 20% increase in the UK in people over the age of 65. We are all living longer, and we want to live that extended life in the best health, and have the best quality of life that we can. These are the slides that would mirror that from an Irish perspective. And 82% of people felt that menopause was not openly discussed. And it's only through events like this and others that we can really get this conversation going, get it in the workplace, get it in the home. For any of those documentaries that have been on television, certainly make any family members watch them with you so they can try and empathize and understand how challenging it can be from a menopausal point of view. And that's before we take in the other chronic illness you have in terms of epilepsy. I also should have said from the outset, I have a family member here, one of my daughters has epilepsy, so I'm quite familiar with how the impact on even hormonal changes can have on seizure control. More than half of women describe menopause as a negative experience, and we really want to think about turning into that second and third half of our lives as a positive experience. So we have to say, how can we turn the dial? How can we change the conversation around that? And we need to not just make it a female conversation. When we see at the bottom left, 77% of men in Ireland are uncomfortable talking about menopause. And that's really from a lack of information, a lack of understanding. So we have a job in hand, healthcare professionals, women, media, and everyone that we know, to try and get the conversation, to take the mystery out of menopause and get the conversation going so we can talk about it in a very wholesome, positive way and try and get the best out of it. So what happens during the menopause? So menopause literally means the last menstrual period. And periods stop because hormonal fluctuations carry on during perimenopause, and eventually then they deplete at such a low level of estrogen and progesterone that the stimulation of the lining of the womb doesn't happen. Those levels fluctuate and eventually become so low that the endometrium thins so much that it doesn't bleed. Menopause is defined once it's been 12 months since your last natural bleed. It can happen naturally, that's a natural menopause. It can also happen for other reasons, such as removal of the ovaries, perhaps chemotherapy or radiotherapy, perhaps a full hysterectomy, perhaps there's been period problems for a number of months or years up to that. So there can be surgical reasons, there can be medical menopause, there can be sometimes a no known reason for why menopause has happened earlier. So there can just be no reason, or it can just be the way it is. Some phrases you might hear will be climacteric, which is that time in which the hormone levels are beginning to change. And perimenopause is another term that we hear a lot of. So perimenopause is in that period, perimenopause transition from the beginning of menopausal symptoms right up until you're postmenopausal. And postmenopausal is the time following the last period, and we defined as someone who's no periods and someone who is intact ovaries or immediately following surgery if the ovaries have been removed. When would we expect menopause? The average age is around 51, 52, but it can occur much earlier and it can occur a little bit later. That's just the average age. And perimenopause can occur for quite a number of years before that. Menopause happening before the age of 45 would be called or termed early menopause, and before the age of 40 would be premature menopause or perhaps ovarian failure. Generally, women are advised with having early premature menopause are advised certainly to take HRT unless it's contraindicated until they've reached the average age of menopause, both for symptom control, but also to protect their bones and the cardiovascular protective effects. Menopause can happen, but usually by the age of 54, the majority of women will have stopped having periods. And the age of onset can be determined by a large number of factors, and it's only a guide. It's not certainly not an exact science. And many of you here might be asked, when did your mother go through menopause, or your sisters, or any female relatives? Well, we're still of a generation where the generation before us didn't really talk about it very much. And I ask that question of very many women in the pharmacy, when did your mother go through menopause? And it might be a case of she never said, she just tells me she just sailed through it. And that generation seemed to think that there might have been a gold star at the end of menopause if they go through it, just keeping it quiet. But actually, we know there's not. So it's good to have this conversation open. We're actually doing the next generation a favour by actually keeping the conversation open and knowing, actually, this is when it happened. This is what happened for me. These are the effects that maybe happened. Is there osteoporosis a risk, or what's going on? External factors such as maybe if you had restricted growth when you're in gestation, if you were a low weight infant, or maybe not nutritionally adequate in infancy, if you had developed quite puberty or periods before the age of 11, or if you've had no children at all, that can all increase the risk of early menopause. Developed countries, which I believe actually can go into menopause about a year and a half earlier on average. And smoking status, for women that smoke, they're more likely to go into early menopause. And the significance of all of this is, as I said at the outset, to remember that we are living longer, and the earlier we go into menopause means the longer that we have to live with that hormone depletion. So the risks and the complications that can happen, osteoporosis and cardiovascular events, we have to protect ourselves for longer. We want to have the best physical shape, the best physical body, the best selves that we have to live with as we live into old age and enjoy that. I'm very often asked in pharmacy when people come in with a variety of symptoms, am I in menopause? Am I in perimenopause? Have I finished my menopause? Particularly if they perhaps have a Mirena coil in place, or for some reason, perhaps they've had an ablation, for some reason that they're not experiencing periods. It's really hard to tell. But symptoms is first and foremost is what we go with. And there's no myth that if there's no hot flushes, that you're certainly not in menopause, that there might be some other reason. But some women may go through menopause and not have any night sweats and not have any hot flushes, or very, very few, but might have some other very debilitating symptoms. So it's important to know that there could be 30 or 40 different symptoms, and you might experience some of them, you might experience all of them. And as Mary said at the outset, everyone's menopause journey is very, very different. Your experience and your symptoms are very different in both the frequency, the severity, the intensity, even they change from month to month. So just be very clear that you're an individual and you know your body best. So to ask yourself if I'm in perimenopause or menopause, the average age is usually begins 45 and finishes usually around 55, but it can happen earlier, can happen a little bit later. Menopausal symptoms can begin like anxiety, low mood, with brain fog, before even the irregular periods. And these symptoms can start for years before periods stop or start fluctuating, and continue for some years afterwards. And this is why oftentimes women can be experiencing these symptoms, particularly these vasomotor symptoms of flushes even, low mood. They can experience these symptoms for a couple of years before we actually think maybe this is a hormonal imbalance. And these symptoms can have a huge impact on your life. As we said at the outset, 84% feeling that they really weren't prepared, 75% feeling that their job, their day-to-day life was really negatively impacted. So don't underestimate this impact, and look at all the things that both myself and Claire can bring to you this evening to think, what can I do to help manage my symptoms and also protect myself in later life? And it will come down to medication will suit some, it won't suit everyone, but menopausal symptoms will certainly improve with some lifestyle changes. The vasomotor symptoms, such as the hot flushes and night sweats, don't affect everyone, but they can affect a lot of women. They tend to happen early on in perimenopause, and they can lead to more debilitating effects. Oftentimes people will talk about having just had the shower, just going out the door to go to work, go for a night out, and they're absolutely drenched. Maybe they'll just have a cup of coffee and suddenly they've broke out in a night sweat or a day sweat, or perhaps they're dressed up, ready to go to a lovely event, the hair is done, the makeup is on, and it's all just running down. And that's really, that impacts on your day-to-day, that impacts on your drive to want to go out, that impacts on you wanting to socialize, it impacts on just even getting through some days. The psychological symptoms, low mood, anxiety, irritability, mood swings, lack of energy, lack of motivation. Oftentimes I see women who perhaps have been diagnosed with a mood disorder, or perhaps maybe with depression or generalized anxiety. And sometimes it might not be that. It might be down to menopausal symptoms that weren't recognized perhaps early enough. The urogenital symptoms, probably the least talked about, and Claire might comment on this as well. Vaginal dryness, painful sex, and frequency and discomfort of urination. These can all really impact with sexual dysfunction. Add in low mood, irritability, mood swings, lack of energy. Sexual dysfunction is a huge impact of menopause, and it's something that's not talked about very often, and we're trying to have it talked about much more because it can be treated, and can be treated really quite successfully. And then other symptoms: dry skin, dry hair, dry eyes, itchy, aches, pains. I had one woman about this time last week, or last Thursday or Friday, in the pharmacy, and she just said to me, we were chatting about her HRT, and I was asking her how she was getting on. And she said sometimes she feels like she wakens up and she just thinks, which bit of me is sore today? What bit of me is broken today? What bit of me is vanjaxed? And there is that sense sometimes. So I suppose it's really important to know that you're not on your own, and the conversation that is going along is really, really important. I have a little, I think it's the next slide. The slide coming up in a little while, and with all 40 symptoms listed. And I had put out on our own social media recently a checklist, and women wanted to know if there was a prize at the end, depending on how many boxes you ticked, because actually you can tick so many. You could tick all of those and maybe not have one hot flush. So to have that reassurance that you can be on a menopausal journey and not realize it, and there is treatment and there is help available. So if any of this sounds familiar, as I said, fluctuating and gradual decline of estrogen during perimenopausal stage, or that menopause transition, the early signs are what flushes, the vasomotor symptoms, mood changes, disturbed sleep, joint aches and pains, and then the weight change. And the fat distribution that would naturally have, women tend to be a pear shape up until late 30s, early 40s. And then as we progress through the 40s into early 50s, the fat redistributes itself and shifts to the apple shape rather than the pear shape. And that would have a greater impact on our cardiovascular health. So often when women are chatting to me about HRT and will they put on weight because of HRT or they lose weight because of HRT, it tends to be more the physical transition that we go through during menopausal years rather than HRT itself. And that's really important to remember. But we add into that symptoms such as low mood, lack of motivation, aching joints and muscle pain. It's really hard to exercise when you're feeling all of that. The weight will tend to gather a little bit more. So it's really important that we do, and I'll talk about it later on, we do maintain our exercise and we do maintain our strength training and we do maintain our flexibility and mobility work. Symptoms around vagina and bladder issues, dryness, irritation, itch, discomfort are often thought to be later symptoms, but some women do notice them in perimenopause. We would be always on the watch out for women of a certain age, from the age of about 40. If women start presenting to me with frequent urinary tract infections or frequent bouts of cystitis or frequent bouts of thrush, I quiz them a little bit more around when is it happening, what exact symptoms are they having. And just so for your own information, I would class any more than 2 bouts of thrush in 6 months. Any more than that for me is a red flag, and it would be actually, I don't think we're dealing with thrush here, and maybe a case of an estrogen imbalance or estrogen depletion. So just bear that in mind if there are any vaginal or bladder symptoms going on for you, and you might not have associated them with hormonal depletion. It might be worth just checking with the pharmacist, your nurse, or your GP. Symptoms can be mild initially, especially in the early days, and you can be in perimenopause, maybe from your late 30s. Because periods are still present, the hormones are still at a certain level. And it's only, as I said, sometimes when women look back, that some of those early symptoms, the mood changes, sleep change, all of that, they look back and think, actually, maybe I've been experiencing this for a little bit longer, and they become more pronounced as the hormone fluctuation continues and as periods might become a little bit more scattered, they may become heavy. And find women might have periods really heavy for a month or two, might have nothing for 3 or 4 months, maybe a really heavy one and nothing. And that unpredictability can be quite distressing. The average duration of menopause is around 7 years. But to be honest, when we take perimenopausal symptoms into it, I think it's a little bit longer, and symptoms can very often persist beyond 60. I have certainly women in my practice that still take HRT, still use HRT, late 60s, early 70s, and I have one lady in her 80s that absolutely still experiences some symptoms and still uses HRT. It's important that we have conversations like this and these early changes are recognised. So discussions take place among groups of friends, within your healthcare professional setting, you actually are prepared and you know what's happening. So if you're experiencing anything like this, we've seen some women who've been diagnosed query autoimmune disorders such as rheumatoid arthritis, which does increase in frequency and prevalence as we come into our 40s and 50s, but perhaps they have been actually misdiagnosed as rheumatoid arthritis, but actually we've switched them to HRT and we've seen a very positive impact. So it's really important that we're aware of all the symptoms, that you recognise them and actually fill in some of the questionnaires, score charts, see how you're getting on, and actually just go in fully informed to your healthcare practitioner and know what's happening and what we can do about it. This is the one, so maybe just take a moment to go through, and there's that sense sometimes, am I going crazy? Am I really having all of these symptoms? And you can't actually be having all of these symptoms. Some of the less talked about ones are tinnitus, ringing in the ears, vertigo, dizziness, bit of hair loss, people experiencing allergies that they never did before, poor concentration. How many times do we go to the fridge and not know what to go for, go upstairs, what did I come up here for? You have to retrace your steps, and how many of us are feeling like we're turning into our mothers? That's, I suppose, what we witnessed back then. So that's just there for you to know. Okay, and this one, I took this offline. There's some spelling mistakes in it, but I just thought it was a funny one. My bedtime routine: go to my bedside to my lower back physio, plantar fasciitis physio, my tendinitis physio, pelvic floor exercises, my thinning hair rub tonic, lower body with magnesium spray for achy joints, lavender on my pillow, eye ointment in my eyes, eye mask for my dry eyes, pillow between my legs, into bed about an hour later. And the husband's routine is go to bed, get into bed. And that pretty much sums up an awful lot what we do, just to get a bit of comfort and get through the evening. There are some myths around menopause and perimenopause, so it's really important that we try and bust some of those. And Claire will pick up on some of these topics as well. That it happens overnight, and it really doesn't. It can take years before we realize that we're in full flight. And I suppose this is what we're noticing now. There are women, and when I talk about supply around HRT, treatment for menopause and HRT dispensing has gone through the roof, because now these conversations are happening. And I've had women tell me about, "God, I wish I tackled this 5, 10 years ago. I wish I'd known." Because when I look back, this was such a gradual onset, and then suddenly they feel like, what's happened to me? The person I look in the mirror isn't looking back. And where am I? And let's try and find some of yourself back. That the symptoms are purely physical. They're absolutely not. And there's that old, some people may say, but you don't have hot flushes, so you can't be in menopause. But as I said, there's so many other symptoms between the psychological, the physical, not necessarily hot flushes, but aches and pains, and then the psychological and the urogenital symptoms as well. It's all about the hot flushes. Well, we've covered that one off. It's absolutely not. Menopause begins at 50. I have women certainly on HRT, maybe from late 30s, if they're in active perimenopause. It will affect your sex life adversely. It won't. It can do, but there is treatment for that. It's not to absolutely write yourself off and this is the way it's supposed to be. So it's actually okay. If your sex life is adversely affected, that has an impact on every other aspect of your life as well. So it's another part of your life that can be treated. So even if libido was low, there is medicine to treat that, and it might be worth trying. That you can ditch contraception immediately, and this is a really important one. Absolutely not. And it's important that your contraceptive care is looked after and that you are being careful. Sex life is going okay, that you do use effective contraception. Even if the periods aren't happening regularly, there is still a risk of pregnancy, and certainly the last thing any woman in their late 40s, early 50s would want. So we have to make sure that you really are using effective contraception. And that's where something like the Mirena coil is really effective, because it can be used for contraception, but also as a progestogen in terms of uterine or endometrial protection as well. So it does have that dual effect. HRT is the last resort, and delay is inevitable. I don't hear quite as much, but up until probably about a year and a half ago, I had a lot of women who would have said, "Oh no, I'm trying to get through without it." And then I suppose when we look at the converse, if we take any other condition, you wouldn't be saying, "Oh, I'll try and get through without treatment," if your symptoms were, really impacting the quality of your life. You certainly wouldn't be going through cardiovascular disease or diabetes, and certainly not epilepsy, but thinking, I'll get along without medication. So it's certainly not to be seen as a last resort. It's to be seen as something to help the symptoms, if it's suitable for you and it works, something to help the symptoms that you're experiencing currently, and also helps give you some protection for your bones and your heart for later in life. So it's really important to dispel that myth. But life won't be the same again. We're seeing now people entering the third stage of life and really enjoying their life. If you can enjoy your life with a great physical self, not having some of the psychological impact that menopause can have on you, you can actually have a really good quality life as you journey through the menopausal years and come out the other end. And that you have to have hormonal blood tests. And this is something I'm sure Claire will speak to as well. Hormonal blood tests after the age of 45 aren't really recommended, because it's assumed at that stage you're close enough to the average age of menopause that you are in perimenopause, if not menopausal at that stage. So you don't have to have hormonal blood tests if you're over the age of 45. Under the age of 45, it is recommended. So just speak to your prescriber, speak to your general practitioner or your menopause team and see what they recommend. But over the age of 45, it's not clinically recommended. In terms of treatment, just talk very briefly around HRT and the hormones involved. The hormones involved initially are estrogen, estrogen, and testosterone. Estrogen is given continuously. Ovaries produce estrogen and a little bit of testosterone. And as the ovaries deplete, estrogen levels drop, and that's what causes an awful lot of your menopausal symptoms. In women that haven't had a hysterectomy and they have a fully intact uterus, progestogen must be given to reduce the risk of any endometrial overgrowth or hyperplasia or endometrial cancer. It's really important that progestogen is given, and it be given in a variety of ways, whether it's an oral route or whether it's a vaginal route, or as I say, in the form of the levonorgestrel coil, which can be in place for 6 years for contraception and 8 years for HRT use. And then testosterone can be used in very, very low dose off-license use for low libido. So hypoactive sexual desire disorder, or really low libido or very little interest in sexual function. That's really when other complications such as vaginal dryness, fatigue, low energy, any relationship issues, we rule all of those out. It's not just as simple as let's go in with testosterone, and that's what we're trying to balance. It is unlicensed for this use in Ireland. So with that always comes risks. So we don't go straight to testosterone, but it's not to say that if it's necessary, it has had some really positive effects for women and a really positive impact on their life. So with those three main hormones involved, I like to give most ownership around the HRT journey back to women. There's a huge amount of choice around it. And when we come to some of the products and the preparations available, it may be a case that some women need transdermal or estrogen on their skin. They may need an IUD, a hormonal coil, a Mirena coil in place. They may also be taking oral progestogen, perhaps, maybe not. And they may also have testosterone. And that's all absolutely fine. They're all treating different symptoms. We're all just trying to tweak and see what fits you, what's the best for you. And if something's not working, you have the entire control to go, actually, it's not for me. Let's come off it. Let's try something else. Perhaps I don't like using a patch. Perhaps I prefer a gel. Perhaps I prefer a spray. Let's see what works best for you. So it's really to empower you with your journey through this, that you have ownership within it. And patient preference has to be the first and foremost indicator or decider in whatever route we decide. In terms of the route of delivery of a medicine for HRT, it tends to be mainly oral or transdermal. So oral is obviously an oral medicine that we swallow, and transdermal is a preparation that goes onto the skin. Oral medicines are very cost effective and very easily tolerated. However, they have a greater risk associated with them. We do find that non-oral or transdermal preparations for HRT certainly are much more they're much safer. They have a safer metabolic effect. So, and this is very pertinent to epilepsy patients because they avoid this first pass effect on the liver. Very many anticonvulsant medications are enzyme inducers or liver enzyme inducers and actually can impact the oral medication. So it's best for anyone using the medicine that's a liver enzyme inducer that they do use a transdermal preparation. But also just generally, they have a safer profile. So most prescribing now is on the transdermal route. So whether it's a patch or a gel, for the majority, I'd say 9 out of 10, maybe even 19 out of 20 prescriptions for HRT, it'll be a transdermal route. And then estrogen can also be given intravaginally for vaginal symptoms. With that, there is very, very little systemic or very little absorption into the bloodstream. So if you do not want to use HRT as such, you can still use estrogen in the vaginal area to treat any of those urogenitary problems such as dryness and vaginal atrophy and irritation. The reasons for the indications for the non-oral or the transdermal route is number one, it's patient preference. And that's what I'm finding most patients are preferring. They prefer the patch or the gel. Absolutely, that's what they prefer. Safety profile is there. There isn't great symptom control with oral treatment, and there tends to be a lot of side effects in terms of nausea. There's a greater risk of clot. There's a greater risk of clot when their BMI is over 30. There's a risk in terms of blood pressure control, and as I said, liver enzyme problems. So generally, the non-oral route is the way to go. Some women may still prefer to try HRT in a tablet form for whatever reason. Perhaps they react or just don't wish to use transdermal route. But generally, we're finding that women are using patch or gel for the estrogen therapy. In terms of the regimen, so there's a lot of complication out there. And if you either are taking HRT or you might know someone taking HRT, you might find some of your friends or colleagues, everyone's HRT regimen might be slightly different. And that just depends on what stage they're at. So cyclical or sequential HRT is almost mimicking the natural period, but it's recommended for women who have menopausal symptoms but still have regular periods. And that can either be through monthly HRT, whereby we use estrogen every day. So it's released into the skin either through gel or oral route or through a patch. Progestogen is usually taken alongside for the last 14 days of the cycle, and that's recommended when the woman is still having regular periods. The progestogen is taken for the last 14 days just to protect endometrium, as I said, from overgrowth, from cancers when there's a surge towards the end of the cycle. Other women may use 3 monthly HRT. So again, estrogen every day using a patch or gel, and use progestogen or tablet, and use progestogen for about 14 days at the end of every 3 months. And that's when there's a very irregular bleed, and that will bring on a bleed at the end of every 3 months. That's how they would work. For women who are postmenopausal and haven't had a bleed, continuous combined HRT is usually what's recommended. So these are women that wouldn't have had a period for 12 months. The continuous combined HRT is estrogen and progestogen every day without a break. And that can be transdermal, so an estrogen patch or gel or tablet, and progestogen tablet every day without a break. With some women, I have found, I want to just think of one or two at the minute, who this may prompt some breakthrough bleeding, and that can happen. But once that settles, then it should settle okay. I've had one or two women where maybe it has precipitated a greater bleed, and we've had to refer back to prescriber for that. So it's always, don't feel, if I've chosen to go down the HRT route and it's just not working for me, or I'm having a little bit of problems, it's not the first option is the only option. There's lots of ways of tweaking it around. It might be in terms of the strength of the progestogen, strength of the estrogen used, it might be the form of the estrogen used. So lots of ways of tweaking this around. So don't think the first option offered to you, if you've chosen to go down the HRT route, is the only option offered to you. There's lots out there, and it's really important that you have that information, that you know, actually, I can go back, but this isn't working for me. I've given it 3 months. What's next? We'll try the next thing. There are side effects with HRT, like with every medicine, and with everything we have to do what's called a risk and benefit analysis, and we have to decide actually are the risks of side effects or the risks with this medicine associated with this medicine, do those risks outweigh the benefit, or do the benefit of this medicine outweigh the risks, and what am I prepared to take? I'm really in favour of shared decision making with the patient. So once the patient is fully informed of any medicine and any condition, but particularly around women's healthcare, once you're fully informed of all the pros, the cons, the risks, the benefits of the medicine, then that you are a decision maker in your own care. You can actually say, yeah, do you know what? Maybe I'll give HRT a try. Maybe I'll give it 3 months or 6 months and I'll see how it works for me. Or you might say, actually, I'm not willing to give it a try just yet. I might try some other avenues, the non-HRT avenues, maybe other medicines, and we'll try that, or maybe not. It's really important that you have that vision in your head of a shared decision, that this isn't forced upon you, nor is it denied to you, that actually you have a shared decision, shared capacity in this decision. Side effects of the estrogen element of HRT, they're very similar to when you think of premenstrual tension, or even just some of the menopausal symptoms: bloating, breast tenderness, swelling in other parts of the body, a bit of nausea, leg cramps, headache, indigestion, and vaginal bleeding. And then the side effects of digestion, very similar in terms of breast tenderness, swelling, headaches, migraines, mood swings, depression, acne, abdominal pain, back pain, vaginal bleeding. So when you think back maybe in your early teens or mid-teens, if you ever had, those kind of few days coming up to a period, those progestogen effects, the mood swings that you might have had a skin breakout, maybe a migraine, that's the progestogen side effects. And then the estrogen side effects, maybe the breast tenderness and that. These don't happen everyone. They do happen some people, and it just depends. Sometimes it might be tweaking of the dose of progesterone, maybe tweaking of the dose of estrogen. So just again, the first option isn't the only option. And if it works and it's fine, you've no side effects, that's fine too. These are just some of the preparations that are available for HRT. You may or may not, if you're using HRT, recognize some or all of them. And it's only a fraction. In Ireland, I think we have, in the UK, there's 72 forms of estrogen transdermally that are available, and in Ireland there were 12. So when we experience shortages, there's a really significant problem. So we can see here there's a few different types of patches, a few different types of gels. We can can switch between when there's a shortage. Around this time last year, there was a significant shortage of HRT. If you think that you're having really debilitating or distressing menopausal symptoms, and you have stabilized that, you're having symptom control, and suddenly your medicine has been taken off the market, or suddenly your medicine can't be sourced, or if you've been really settled on a particular patch and we can't get that brand of patch, and I have to tell you maybe the second month that we need to cut a patch in half, or the next month I have to give you a spray instead of a patch, and then month 4 might be a gel instead of a patch. It's really, really distressing for you as a patient, and we absolutely understand that. However, because of the really successful public health awareness campaign that there's been, and because women are talking about HRT and are talking about menopause care, the demand has exceeded supply. So supply, we get an awful lot of our medicines from Europe. And because Ireland is a very small country and there's only about 5 million people here, and we're an island off the west coast of Europe, there are supply chain problems to get medicines to Ireland, just generally, not just HRT. And because the demand in HRT has exponentially grown throughout the world, but particularly in Europe, the UK and Ireland, the supply, there's a lag time between what the manufacturing plants can make and what we can provide to patients. All the while, more patients are seeking help, seeking treatment, and there wasn't the stock to catch up. It has improved significantly since this time last year. Still is a challenge. I still see on the screen there, some of you might be familiar with Vagifem, and just beside it I have Vagirux. They are topical, they are estrogen that can be delivered. They're almost like a shape of a tampon. They get estrogen that can be delivered straight into the vagina for vaginal dryness, and they're in quite intermittent supply at the minute, which is really just, really distressing for women who maybe have just really spent a number of months getting on top of vaginal symptoms. Maybe the quality of life is improved, and suddenly then we can't get that. So I'm switching between products at the minute. So that's a challenge, and we absolutely understand that's a challenge for women. In terms of the supply issues, exactly what I said, there's ongoing supply issues for the last number of years, particularly in the past 2 years, mostly because of increased public awareness. And rightly so, that open conversation has led to more women seeking treatment. We had Brexit, where the UK stockpiled an awful lot of medicines. COVID then allowed for, or facilitated, a lot of manufacturing interruption, and then just general supply chain issues, the war in Ukraine. All of this had a massive impact. What we have asked is that we could directly switch. So if any of you use HRT and have experienced a supply shortage, what has happened is, if you have come into me and actually, even for some of your epilepsy medicines, there have been significant shortages. If there's a supply shortage for a medicine, I can't directly switch you to another preparation. I must then go back to your prescriber and get it switched to something else, and then wait on them coming back to me, and then I can dispense the alternative medicine. For some medicines, that's absolutely critical and necessary, but for other medicines that are dose equivalent, like HRT, it would make for greater sense that we could just switch you from a patch to a gel, to a spray, to a patch, depending on what was available at the time. So I'm hopeful, and we've been campaigning for a long time, I'm hopeful that will happen. Certainly from the minister we heard the other day that it's going to happen hopefully within the next few months. and that would make for an easier transition and less delay in treatment for women. There are plenty of complementary and alternative therapies. There are alternative pharmacological therapies and treat symptoms of menopause. There are some antidepressants that are useful in low doses that can treat some of those vasomotor symptoms, such as hot flushes. So if you really, for some reason, maybe aren't able to take HRT, perhaps it's contraindicated in your own personal situation, or that you've chosen not to take HRT, there are some medicines that can be used to treat the vasomotor symptoms. There are low-dose antidepressants that can be used, as I said. There are complementary and alternative treatments. There are quite a few herbal and natural hormones. Certainly not recommended unless it's worth remembering that any herbal and homeopathic medications have a great potential to interact with prescription medications, and particularly medications used to treat epilepsy. There's an awful lot of herbal preparations that would be recommended for menopausal symptoms, such as Agnus castus, or St. John's wort, or ginkgo biloba, black cohosh. A lot of these have significant drug interactions, so it's very important you do inform your pharmacist or check with your pharmacist or your GP before you begin taking anything else. That it's safe with any medication, not just epilepsy medication, but anything else that you take. It's also worth remembering that they're not through the same rigorous clinical trials that licensed medications have to be. So it's not really clear how safe and how effective they are. And as Mary said at the outset, we can only really send over recommendations for things that have evidence to back up their use, where we know it's safe and effective treatment. There are lifestyle changes that are absolutely essential to symptom management, and we can talk through those in a little while. But it's really important to check with your pharmacist for any advice before you use any complementary preparation. In terms of lifestyle changes, it's really important to get plenty of rest. And that's really easy to say, and it's hard to do if your sleep is disrupted because of menopausal symptoms. But very simple things like keeping regular sleep routine, looking at your sleep hygiene, maybe, ditching the blue light on the phone or the television before bed, try and get in 20 minutes, just rest and sleep, or rest and read before sleep. Eating a healthy diet, checking your caffeine intake, checking alcohol intake, particularly if you're experiencing quite a lot of hot flushes, because these do act as a vasodilator. They do open up the blood flow. They do enhance the hot flush effect. Have a calcium-rich food. It's really important. Our bones are the only bones that we have to live with, and our bones really have to be kept strong. So milk, yogurt, kale, all of those kind of things help keep bones healthy. Exercising regularly, so weight-bearing activities where your feet and legs support your weight, like walking and dancing, running, and relaxing things like yoga, tai chi, and meditation. I try and talk to my patients about, if we take the rule of 2, you try and do 2 cardio activities a week. So whether it's a good brisk walk, certainly twice a week if you can, 2 strength training exercises a week. And it doesn't have to you don't have to go to a gym to lift weights. It can be simply using your own body as a resistance, and then to do 2 mobility sessions a week. So simple yoga routines, Pilates, anything that will help with our flexibility and our mobility. Very often, about once a week in my yoga classes, everyone's pretty much the same age, men and women, and I will get them to try mobility tests, like getting up off the floor without using their hands, getting up chairs without using their hands. And it's really important that we keep that mobility and flexibility in our bodies for as long as we can, because if we have a fall, we need the strongest body that we have to recover quickly. Talk to other people going through the same thing, families, friends, colleagues. It's really important to know that you're not on your own, that half the population will go through menopause at some stage. Women will go through it. It's a normal transition through life, but there are significant symptoms. So you can have help and support in talking through symptoms with other people. Talk to your doctor, talk to your pharmacist before you take any herbal supplements or complementary medicines. They're all the do's. The don'ts are simply don't smoke whatsoever, and certainly don't drink more than the recommended alcohol unit per week. And certainly not more than 2 alcohol units per day, or 14 units in the week. And with that, I'm happy to hand over to Claire, who will talk you through the more complex element of menopause.
Thank you very much, Kathy. That's brilliant. Claire, straight over to you, and just to remind people, if any questions they want to put in the chat box, please do feel free to do so. Thanks very much.
Hi everyone, that was a really informative talk there. I'm sure everyone got a lot out of that. So I'm really just going to pick up where Kathy left off. Let's see. So I suppose my role as the clinical nurse manager in the Complex Menopause Service, I am developing the role of the clinical nurse specialist, working alongside our two menopause specialist doctors. I suppose my biggest role is supporting the patients coming through our service, educating them, listening to them. A lot of women feel like they are going mad at this stage in their lives, and I'm there to reassure them that they're not. So it's really important just to listen to women's symptoms, listen to their stories, their concerns, reassure them, provide them with the support, and signpost them to relevant and reliable evidence-based information and education. There's a lot out there on Google. You'll hear some horror stories and some scaremongering as well, and it's all about going to the right place to get the good quality evidence-based information and education. And really what we want to do is empower women like yourselves to know what's going on in your body, to know how to manage your menopause and your symptoms, and to make a decision on how you want to manage your menopause or treat it going forward. So as we were saying, we spend a huge number of years now in a postmenopausal state. You could spend 30 or 40 years if you're lucky in that state. So it's really, really important that you're going into those years of your life as healthy as you possibly can. So again, as Kathy has discussed, we really do want women to optimize their health and modify any risks they have. So, to take a look at the diet, the exercise, pelvic floor, smoking and alcohol, sleep, stress, and to make sure you're up to date with your screening. And then obviously any treatment options that you may want, the most effective one being hormone replacement therapy. So just to touch again on the smoking and alcohol, it is smoking obviously takes about 10 to 15 quality years off your life. It's a huge damage to your health, contributes to the risk of heart disease, cancer, osteoporosis, damages your skin, hair and teeth, costs a lot of money, and it really drives the vasomotor symptoms. So those hot flushes and night sweats can be really worsened. If you smoke, it affects your mood and your quality of sleep. So we would really recommend our patients to quit. They can visit quit.ie. If they were attending our service, we could also refer them to a smoking cessation nurse for some support and education and nicotine replacement therapy. Alcohol and caffeine then as well. Both of those increase your vasomotor symptoms too. So really drives those flushes and sweats, affects your sleep, can make you anxious, lowers your mood, and the caffeine can also irritate the bladder as well. So we do recommend that you drink no more than 2 cups of tea or coffee per day and no more than 14 units of alcohol per week. So that is about 1.5 bottles of wine. Red wine, if you drink red wine, we would advise you to maybe switch to white, just because red wine really, really contributes to those hot flushes and night sweats as well. So it's really not the best. If you're going to drink alcohol, it's not the best one to drink at all. Care of the pelvic floor then is really, really important. So as our estrogen levels fall, it affects the lining of the bladder and the urinary tract, and we see changes such as weakness in bladder and bowel dysfunction. So common issues then are the urinary incontinence. So if you have any leaking, an overactive bladder, if you have urgency and frequency, maybe signs of a prolapse, you feel like something is coming down, constipation where the bowels aren't going regularly, recurrent urinary tract infections, or vaginal dryness, irritation, pain when you're having sex. So we would recommend pelvic floor exercises that you should only be peeing about 6 to 8 times in 24 hours. So any more than that, and it is frequency. Drinking about 1.5 litres of water a day and reducing your caffeine to 2 cups of tea or coffee, and making sure you're getting fibre in the diet and that you're keeping hydrated for the bowel. Also just to avoid straining when you're having a bowel motion, and maybe to use a raised footstool. Again, to maintain a healthy weight, stop smoking, doing the appropriate exercise. So I don't like to say avoid running and jumping jacks. Some people are really avid runners and very passionate about it. And I think if you are doing an exercise or a sport that you really, really enjoy, and you are having issues with bladder dysfunction, if you are like leaking isn't normal, it's common, but it's not normal. So if you are having issues with incontinence, it's really, really important that you see your GP. Some of these things can be fixed very easily with some vaginal estrogen, with some pelvic floor exercises, or attending a women's health physio. Sometimes you might need a little bit of medication, or maybe to see a urogynecologist, but definitely if you are having any issues with your pelvic floor or bladder dysfunction, please do see your GP. Yoga and Pilates can be quite beneficial as well, strengthen the core and strengthen the pelvic floor. There are over-the-counter moisturizers and lubricants you can get for the vaginal dryness. They can work quite well. Just best to speak to your pharmacist, see what they have in stock or what they might recommend. We would recommend a lubricant for sexual intercourse as well, but just be mindful if you are using condoms, just make sure that the lubricant is water-based. And there's really good pelvic floor education videos on the Pelvic Floor Centre for St. Michael's Hospital. That's just good to have a little look at as well. So managing those hot flushes and night sweats, they account for about 70 to 80% of women will suffer with hot flushes and night sweats to some extent. Some really aren't bothered by them, where others, it really, really affects their quality of life. So a flush may feel different from one person to the other. Some women describe it as a tingling in their fingers, maybe palpitations where their heart is beating faster, or it just feels like it's going to come out of their chest. The skin can feel warm, or maybe a general rise in heat. They might say like they can just feel the heat rising from their feet right up through their body. The face can get red and flushed. Some might sweat, and some might sweat profusely. And women then waking up in the middle of the night soaking wet, where they actually have to have a shower, where they have to change their pajamas, where they have to change their bedclothes, getting absolutely no sleep, huge disruption, and really affecting their quality of life. So things that can trigger a hot flush, things like caffeine, spicy foods, smoking, intense exercise, sometimes if you're feeling pressured or anxious, and also environmental factors. So this hot, humid weather that's going to come in won't help. And I can only imagine I will be getting extra calls over the next few weeks with women saying that they are having some breakthrough symptoms while on their treatment, and it really will be environmental factors. So I will kind of try to reiterate any tips that we have to help manage the hot flushes and night sweats. So we would recommend dressing in layers. It's just easy to remove a layer or adjust your clothing when you start to feel hot. Wear loose fitting clothes made from light fabrics like a cotton. Avoid high or tight fitting clothing around your neck. Maybe keep a cooling mist or spray or a handheld fan in your bag just to help you cool down. Maybe have wipes or body spray just if you need to freshen up. Have a little fan at home or in the workplace just to keep the air cool around you. Stay hydrated, drink your 1.5 litres of water every day. If you do start to feel a flush coming on, try and get your hands in some cold ice water. Reduce your caffeine intake, avoid the spicy food, maintain a healthy weight. And being overweight or obese can have an impact on the severity of your hot flushes and night sweats, so just be mindful of that. So you can see there's a bit of a recurrent theme here about healthy eating, exercise, alcohol, smoking. So again, it is just to be as healthy, we do aim to be as healthy as possible. Reduce the alcohol intake. As I said, they can really drive them. Smoking can make the flushes worse. Allow yourself more time when you're feeling under pressure or stressed or anxious, you may flush more. Yoga and meditation exercises are really beneficial. Maybe download the apps such as the Calm app or the Headspace app just for relaxation. And then going to bed at night, just keep your bedroom cool. Use nice cotton sheets with a low thread count. Wear cotton night clothes as well. Some women do sleep on a towel. I don't know how I'd feel about that, but they do sleep on a towel at night. Just if they do wake up and they have soaked through, that they can just remove the towel and get back to bed without having to change the whole bed. And just as well, maybe to keep a cool pack underneath your pillow, just to keep it nice and cold, and just to turn it regularly as well. Cognitive behavioral therapy is also another treatment that is very effective in the treatment of vasomotor symptoms, anxiety, depression, sleep and stress. In our service, unfortunately, we don't have access to a psychologist or a psychotherapist that can do that can provide cognitive behavioral therapy, but there are apps you can download. There is also a HSC platform online called SilverCloud, which your GP could refer you to. Now, it's not specifically for menopause, but again, it may be beneficial. So cognitive behavioral therapy really focuses on the links between the physical symptoms, your thoughts and feelings, and your behaviors. And there is a good book there by Myra Hunter, Living Well Through the Menopause. You can download it on Audible or get the hard copy, and it's not very expensive. And I have it myself. I did download it on Audible. I'm not a big fan of listening to books. That's just my preference. So I did get the hard copy, and I do find it very good. And I do tend to recommend it to women if it is something that they would like to try. Really important as well, just to keep up to date with your screening. So cervical check, breast check, and bowel check. So it's important now to remember that cervical check is running until the age of 65. Breast check starts at the age of 50. You'll start getting called for your mammogram, and bowel screen then starts at the age of 60. So on those websites, you can check when your next screening test is due. You can put in your PPS number and your date of birth, but just really important to keep up to date with those. So then the long-term consequences of the menopause. So once our estrogen levels start to deplete, it can affect our hearts, it can affect our bones, our brains. So we're at a huge risk then of heart disease. So scarily, heart disease is one of the leading causes of death for postmenopausal women, and you're at 5 times more likely to have a heart attack after the menopause than before. So estrogen does play a really important role in protecting the heart. It relaxes and reduces the inflammation in the blood vessels, keep our blood pressure nice and stable. So the risk factors then for cardiovascular disease are age, your family history, if you smoke, if you're overweight, if you have high blood pressure, or if you have diabetes. So estrogen can have a protective role in heart disease prevention if it is initiated in women below the age of 60 or within 10 years of the onset of menopause. We have started women on estrogen, after the 10 years of menopause or over the age of 60, and that's fine for their symptom control. They've just missed out on that kind of cardioprotective nature of the estrogen, but it is, if you do start it within those 10 years of your periods stopping, it does play a protective role in protecting the heart. So you reduce your risk of cardiovascular disease by, again, eating a healthy, balanced diet, reducing your salt, avoiding processed foods, eating less saturated fats. Make sure you're getting regular exercise, so be about 150 minutes of moderate exercise weekly. Maintaining a healthy weight, stopping smoking, limiting your alcohol, managing your stress levels, checking your blood pressure regularly, and having a cholesterol check with your GP as well. Osteoporosis then, so from our late 30s, our bone density actually starts to decrease naturally. They become weaker, and that can increase the risk of a fracture. So again, estrogen protects and maintains the bone density, and during perimenopause and menopause, the levels are decreasing, so the bone density declines faster. And osteoporosis is when the loss of bone density is severe. Again, the risk factors are family history, if you smoke, and a lack of calcium and vitamin D in the diet. So the diagnosis then, a GP can do a FRAC score to work out your risk, and they can then refer you on for a bone density scan known as a DEXA scan. So HRT has been shown to reduce the risk of fracture, and it can be used to prevent or treat osteoporosis in postmenopausal women. So we would sometimes say to women who come to us, they've had a DEXA, it might show osteoporosis, or it shows osteopenia, which is pre-osteoporosis. And we start them in estrogen, and any strength, once we start putting estrogen back in the body, it's going to start repairing your bones. Now, if you were to have a DEXA scan again in a year, there'd probably be no change on it, and that's fine. It generally takes about 2 to 3 years to see the change on a DEXA, but we would reassure them that once you're putting estrogen back in, your bones are starting to rebuild. So it's a really good benefit. You reduce your risk then by eating a healthy, balanced diet that contains 3 portions of calcium-rich food every day. Consider a vitamin D supplement, and also getting your regular physical activity. So again, the 150 minutes a week, but also 2 muscle strengthening exercises, 2 sessions a week, whether that be strength training with weights or yoga or Pilates, but just really, really good to get the strength exercises in as well. So I know Kathy has went through this in detail, so I won't talk too much about it. The only thing I would just say about testosterone, especially I know within our service anyway, we would absolutely start women on testosterone. We would generally just get them estrogenized first. We would get them established on a regime of estrogen and progestogen if needed. We would see how that makes them feel, because sometimes maybe when you get HRT on board, you might start to feel a little bit better. Again, get the vaginal health back to good working order with some local vaginal estrogen, and things may improve, and the libido might improve. If at that stage it hasn't, of course, testosterone is up for discussion. We just do recommend that you have a baseline blood test done before starting testosterone. We want to check your levels. Again, after starting testosterone, then 3 months later, we would check a level again, just to make sure it's staying within the normal female range. And then if you're going to stay on the testosterone, if you're happy with it, we would just recommend that you have your level checked every year with your GP. If at the 6-month mark, testosterone isn't making any difference, we just stop it. We don't want you taking a hormone that's not making any difference. And I have to say, just from experience, it's kind of 50-50. Some women love it, some women get no real benefit from it. There isn't any evidence. I suppose it is for the use of low libido. Some women do say that maybe it does improve their cognition, their get up and go, they have a little bit more energy, but there's no evidence behind that. It's different. It does vary from woman to woman how they feel about being on it. Again, Kathy has went through these different types of preparations. I suppose a concern that women do talk to us about is the HRT and breast cancer risk. So there is nothing oncogenic in breast cancer. But studies have shown that a small increased risk of breast cancer using combined HRT, so using estrogen and progesterone for 5 years or more. Now, if you just look at the chart there, that's from the British Menopause Society, where we take all our guidance from. So you can see that 23 cases of breast cancer are diagnosed each year in the UK. If you take HRT beyond the 5 years, there's an extra 4 cases. But if you are overweight or obese, there's an extra 30 cases. So the risk of developing breast cancer using long-term HRT is about the same as someone who drinks a glass of wine every night, and is much, much less than someone who is overweight. If you're just using estrogen alone, which the only reason you'd be using estrogen alone is if you didn't have a uterus, that carries little to no change in the risk of breast cancer. So really, when you come to the 5-year mark or 6-year mark, that's completely up to yourself whether you carry on or not. You have to weigh up the risks and benefits. Again, as Kathy was saying, she has women in their 70s and 80s on HRT. We don't put an end date on someone's HRT. We might suggest that after a couple of years, or maybe if they get to a certain age, that they maybe pull back a little bit, just because they might need as much as they're on. But we certainly wouldn't say when you get to 5 years or when you get to 65, you must stop this. That is something that you need to discuss with your prescriber and make an informed decision of. Obviously, if things change, if, unfortunately, if you, had a diagnosis of a breast cancer in the meantime, obviously that's going to change things, or something else that maybe caused a contraindication to continuing on HRT. But from the outset, we don't ever say, okay, this prescription is only going to be for this length of time. That's something that you need to talk to your prescriber about, but just to be aware of the risks and then weigh it up. So our service was set up in November 2021. So it was announced that there was going to be 4 publicly funded clinics in the Republic of Ireland. So ours was the first to open its doors. There are now 6 clinics actually in the country, which is really great to see. So there is also complex services in Meath General Hospital, University Hospital Galway, the Rotunda Hospital, the Coombe Hospital, and then soon to open now over the summer will be Cork University Maternity Hospital. So we do have a very strict clinical criteria and catchment area, and we have to, because the demand for the service is huge. And also these other 6 clinics, they're all regional services. So we're hoping to provide a service to each region. So the clinical criteria to be seen in the clinic at the minute would be if you've had a history of a blood clot, if you have immunological disease, if you have cardiovascular disease, so if you've had a heart attack or an angiogram for anything like that, you could be seen by us. If you've had a stroke, cancer, particularly breast cancers or cancer of the ovaries or the womb, if you have active liver disease or other complex issues such as epilepsy. We take GP referrals from South Dublin, Wicklow, Kildare, Kilkenny and Wexford. And there's a GP referral form available on our website. So I suppose menopause and epilepsy, then there is limited data available. So some data would suggest that severe epilepsy can reduce the age of menopause by 3 to 4 years. Again, there's conflicting data that would say seizure frequency may increase in perimenopause. But the British Menopause Society would recommend that anyone with the history of epilepsy is referred to a menopause specialist. So that would be the likes of ourselves, or if you're in one of the other areas, to a clinic in that area, and we would happily see you to discuss your options. Again, limited data, but to say that HRT can increase seizure activity in postmenopausal women, we would give strong consideration to the route and the regime. Within our clinic, because we are dealing with complex and complicated cases, 99.9% of the HRT we prescribe is transdermal. Like I couldn't even tell you if we've prescribed oral HRT once. It is transdermal, so we give it through the skin. So it would be the patch, gel or spray. And that would generally be how we would deliver it in our service. Again, if we're starting a woman with epilepsy on HRT, we would just advise that she is closely monitored by her team, because maybe her epilepsy medication may need to change if she is having an increase in seizures. Again, we make sure that her cardiovascular and bone risks are optimized. Calcium and vitamin D levels are going to be adequate. And as Kathy was talking about the herbal preparations, again, it's not something that we would recommend in our service. We are dealing with women with complex medical conditions who are on a lot of, heavy duty meds. And if something is strong enough to make you feel better, it can be strong enough to cause you harm. So it's not something that we do recommend personally in our service. So then just the top tips for healthy menopause, just a bit of a recap, just to make sure that you are in a good sleep routine. You're keeping your bedroom cool, avoiding your hot drinks, alcohol and caffeine before bed, keeping a fan in your room, using your cotton sheets with a low thread count, wearing nice cool cotton clothes, and consider yoga meditation for relaxation. That you're eating well, you're getting a balanced diet, low in unsaturated fats, you're eating at least 5 portions of fruit and veg every day. Avoiding the white refined carbs, so choose whole grains instead, and you're getting 2 to 3 servings of low-fat dairy every day. Again, your exercise, your 150 minutes of something that you really enjoy, and your 2 strength sessions a week. Stop smoking and keep your alcohol units under 14. And then just to keep the stress levels down, make sure you're sleeping well, eating well, exercising regularly, stop smoking, cut out the alcohol. Make time for yourself. Just do something that you enjoy, whether it be exercise, leisure, or meeting up with friends. Consider meditation and mindfulness, and do avail of support. Talk to other people, talk to your GP, talk to a counsellor, and that. So resources then to look up. Women's Health Concern is a really good website. It is the patient branch of the British Menopause Society, where we take all our guidance and recommendations from. So it has loads of really good, reliable, up-to-date information. Menopause Matters is another one that's very good. The DAISY network is for any women that are diagnosed with menopause under the age of 40. The Calm app and the Headspace app are also really good, really beneficial, just to help with the stress levels and to help relaxation. And 2 really good books then. Kathy Abernathy is a clinical nurse specialist in the UK and the former chair of the British Menopause Society. Her book is excellent. It's like my little Bible. It's a really good one-stop guide to menopause. And then our very own Dr. Deirdre Lundy has just released her book this year as well. And it is really, really good, really informative, a really good read for anyone interested. We also have some information on our website. You'll find a little symptom checker there as well, and that picture graph of the breast cancer risk that I talked to you about as well, and then just general information on menopause, HRT, and the HRT controversy. And that's it.
So much, Kathy and Claire, 2 really, really informative, and you managed to pack so much information into those 2 sessions. So that was excellent. Just before we go over to the couple of questions, just want to check in as well. Kathy, Claire and Sinead, is there anything you wanted to add there before we take a couple of questions?
I suppose just from an epilepsy point of view specifically, as Claire and Kathy have said, the information is very limited because this hasn't been researched in any great depth. I suppose it's most pertinent probably to those women who have a definite catamenial epilepsy that's related to their cycle in general. And so the research again is a bit conflicting in that it says that the seizures might increase, you know, just before around the perimenopausal, but once the woman is postmenopausal, the seizures will probably reduce because the estrogen isn't as strong there. But just to point out that the research isn't there, and in actual fact, neurologists are probably not the expert in this. You know, contrary to popular opinion, it probably is the like of Claire and Dr. Deirdre Lundy who have the most, and Kathy, who have the most up-to-date knowledge. And from my perspective, there's no reason why a woman can't certainly be trialed on HRT, and I wouldn't advocate that any woman leaves here today with that message, just because I've epilepsy I can't have HRT. That's absolutely not the case. And I suppose as well, it's worth remembering that it's very often the symptoms that might provoke the seizures, as opposed to a change in medicine at all. I know that sometimes estrogen can affect certain drug levels, so certainly with the likes of the oral contraceptive pill, anybody going on that, I would often say to the women, look, get your drug level checked before you go on it, then maybe go on the medicine and then get your drug level checked again, maybe up to 4 weeks afterwards, to see is there any impact. But really for anybody who's going through a stage of life, it's really important to manage your symptoms, to recognize what your symptoms are and to manage them. B, to talk to your neurologist, but it is more a multidisciplinary team approach to this, rather than just referring it back to your neurologist. Do be careful of any over-the-counter medicines, because again, they can interact with your epilepsy medicines. And don't be afraid to try HRT. That's just what I would say. That's it, Mary. Thank you.
Thank you, Sinead. Just at this point, I'm going to stop the recording part just while we take in a couple of questions.